Can you see my screen?
Yes, ma'am.
Yes, ma'am.
All right, good. I think we're going to do a slide seminar today. I think it's the last slide seminar of this OTPP GP number 2. We have run this program for over 3 years now. It has kind of changed a little bit over the years. The first OTPP G2 ran for 2 years, this one for 1 year. And we do this every Tuesday and every Thursday. And everybody is welcome to attend, right? I apologize, there seems to be a little echo, but we don't know why this echo is here, but we'll go on anyway. Yeah. Today is the last slide seminar, and there is no theme to this slide seminar. It's just 4 cases, and the word miscellany means an assortment. So basically, it's an assortment of slides, and we can look at these different slides, and then if there is something that we need to discuss over and above whatever we are seeing, please feel free to put your questions in the chat box. Of course, those students, and I think today we have how many? 1, 2, 3, 4, 5, 6 students, and I hope Dhaval is able to get his internet connection in order. So the 6 students will be interacting with me directly. I'll ask them questions, they can ask me questions, etc. They also have an opportunity to to point out to things, etc., because they know how to use the annotation function of this particular platform, and we'll go on from there. All right. This just happens to be a very nice modern art picture of miscellany, because you can see there's an assortment of things. There are leaves. There's a jar. There seems to be some blocks of some kind. That is modern art for you. And I just thought I quite like modern art. I don't know how many of you do. And I just chose this. And the artist is Jesus Alberto Blanco. I don't know how to get rid of this echo, but I hope it disappears along the way. Okay. So now, who would like to take case number 1? Amrita, are you there? Amrita, can you unmute yourself, and will you like to tackle case number 1?
Yes, ma'am, sure, ma'am.
Good, come on.
64-year-old female, soft cystic mobile swelling on the forearm, growing rapidly over the period of 1 month. Size is 2.5 centimeters.
All right. Okay. Here we are, Amrita. Now describe this.
Ma'am, I see a fibrocollagenous tissue.
Fibrocollagenous tissue. Amrita, we need to do better than that, right? Amrita, do you know, have you been following any of the programs that and the slide seminars that?
Yes, ma'am.
Yes, you do. All right. Do you know that this is low power, right, Amrita?
Yes, ma'am.
All right. So what are the things that we do, or do we try? There are some questions that we have to go through our minds when it is low power. Do you know what those questions are, Amrita, that we should be asking ourselves when we sort of examine something under low power? Any idea at all, Amrita? No. All right. Any of the others know what you're supposed to do at low power? Just me. Hey, what are you supposed to notice at low power? Come on, Amrita.
On the cells, architecture.
Architecture. Okay. What else? Nothing? All right. Jasmine, what would you like to notice at low power?
Ma'am, the cellularity, architecture.
Cellularity and architecture. All right, very good. And now, what do you notice at low power? Are you there, Pranav? Yes,
cellularity, morphology.
Cellularity, morphology. Okay. Remember that you're looking at something at very low power. Yeah, this is extraordinarily low power, don't you think? This is not. Very good. So, what do you normally do, Pranav? Pranav, you've done 4 months of histopathology, right?
Yes, ma'am. Pattern.
Pattern. All right, very good. Anything else?
Arrangement.
Cellular arrangement.
Cellular arrangement is pattern. Yeah. Okay, Pawan.
Whole section.
You see the whole section. All right. If you, I don't know if any of you have been attending any of my slide seminars. Okay. See, from what I understand, you guys don't have a system for what you should be doing, what kind of observations you should make at low power. So let me just reiterate it again. There are 5 questions that I ask myself. Okay. Whenever I'm looking at low power, and you may or you may not want to ask yourself, but I'm offering you a system. Okay. And if you use the system, you are unlikely to miss some observations at low power. Okay. And the first question that you ask yourself is there any normal tissue? All right. So now, Amrita, you want to answer that question?
Yes,
is there any normal tissue?
Yes, ma'am. There is.
There is. Okay. Can you tell me what is that normal tissue?
Fibrous tissue is there.
Fibrous tissue.
Adipocytes
Where
are
this
there.
is, Amrita, you know where this is?
Forearm swelling.
It is a soft cystic mobile swelling on the forearm. Okay. Now, what kind of normal tissue do you expect to find in the forearm? Adipocytes. Okay. Right. Anything else? Anything else that you expect to find in the forearm?
Nerve bundles.
Nerve bundles. Okay.
Muscles.
Who said that? Who was answering the question? Pranav or Pawan? Pawan. I don't know. There are 3 males, and it was a male voice. So what was it, Pawan? Yeah. So what did you say?
The muscles sometimes.
Muscle. All right. So if now listen, it doesn't take much intelligence, right, to know what should be there in the forearm. What should there be? There is skin. There is subcutaneous tissue. There is muscle. There should be some kind of tendons or ligaments or something, depending on where it is. And then finally, you have connective tissue with blood vessels and so on. And then there is bone. Yeah, this is what you expect in the forearm. We don't know where in the forearm which layer of the forearm this is. Isn't that right, Amrita?
Yes,
yeah. So what is this normal tissue that you are able to see at this power? Just tell me, Amrita.
I can see adipocytes. I can see muscle bundles.
You can see muscle bundles. Oh, really, Amrita? Now, Amrita? No, 1 minute.
Yes,
muscle bundles, you said. Okay.
Yes,
so, Amrita, do you want to just ask for annotation? Ask for annotation. You know how to ask you
yes,
that day, right? Very good. All right. Now, please show me where the muscle bundles are. I can see the adipocytes. Okay.
Yes,
I'm just drawing the adipocytes over
yes,
here.
yes.
Now, where are your muscle bundles, please?
No, ma'am, I don't.
So there you are,
Yes,
Amrita.
yes, yes,
You just shot off anything. You said muscle bundles. I don't see any muscle bundles. What kind of muscle do you expect to see, Amrita?
Skeletal muscle.
Skeletal muscle. So do you see skeletal muscle?
No.
No. How would skeletal muscle look, Amrita? It would be bright, eosinophilic.
Yes,
Yes, you can't miss muscle bundle. Skeletal,
Yes,
skeletal muscle, it will just sort of hit you in the face. Yeah.
Yes, ma'am.
So there is no skeletal muscle. All right. Then you said something else. What is that something else you said? You said, I remember many things, that people say. You said fibrous tissue and collagen.
Collagen.
Yes?
Yes,
Yes, Amrita?
yes, ma'am.
Now, what do you mean by normal fibrous tissue, please, Amrita? Tell me what is normal fibrous tissue?
Eosinophil.
No. I don't want you to tell me a theoretical question. When is fibrous tissue normal? Tell me. Now we're talking about the forearm.
It's up.
Where would you expect to see normal fibrous tissue? What?
Abnormally. Like it is
So, if you want to talk about normal fibrous tissue, then your fibrous tissue should be seen in ligaments and tendons, right? Now, do you see ligament in the forearm? No, what you see is tendons, right? So, do you think if there is no skeletal muscle in this, you will see ligament, you will see tendons? No. So, there is no normal fibrous tissue that you expect to see in the forearm, and yet you are seeing fibrous tissue, no? There is
Yes,
fibrous tissue, yes or
yes,
no?
yes.
It is not normal, please. So the only normal thing that you are seeing here is adipose tissue. There is nothing else that is normal. Now that comes to the next question that you have to answer. Yeah. And what is that question? Is there any abnormal tissue? Is the answer to that question yes or no?
Yes.
It is. Okay, so there is abnormal tissue. Now, why do we ask these first two questions, Amrita? Can you think of a good reason why we should ask these two questions? Is there any normal tissue? And number two, is there any abnormal tissue?
Normal tissue to find the origin of.
Yes, very good to know what particular tissue cells or the organ that we are looking at. Yes,
Yes, ma'am.
that's very good. But why do we need to know that?
Uh,
Why do we need to know that?
from which cell or organ
They
arises
very
from.
often they tell you, no? They
Yes,
write in on the TRF test requisition form. They write that this is a biopsy from the stomach. So why do I need to find out or to even remark or ask the question? Is there any stomach? Why do I need to know that?
So that we confirm that it is from the
Why?
confirm the tissue that they have sent.
Yeah, but why? What's the purpose of confirmation? Yeah, Pawan, why? Helper. Why do we need to confirm?
See the site if they mentioned correctly on document, received a correct or not.
In other words, we need to make
So
certain
we could biopsy
there
this.
has been no mix-up, right?
No mix up this. Yes.
Absolutely. So that is one of the first things that we need to do. Is there any normal tissue? Yeah, that's number one. But why do we need to answer the question? Is there any abnormal tissue? After all, this is a biopsy, or this is something that a surgeon or somebody else has sent to us, radiologist or anybody. So why do I ask this question? Is there any abnormal tissue?
Sometimes they
Yes,
ectopic tissue or ectopic. If sometimes you find any ectopic or is ectopic.
Atrophy, ectopic. Well, sometimes somebody has missed the lesion, right? Yeah. So if say this happens in the breast or it happens in other things where you do a needle core biopsy and you've missed the lesion. So we must know whether or not there is anything abnormal. So these are the two questions that we need to ask straight away. Yes, Amrita? Is there any normal tissue?
Yes.
Is there any abnormal tissue? And you know what is the third question? What is the relationship between the normal and the abnormal? So if there is normal and there is abnormal, then what is the relationship between the two? So why should we know this? And what actually should we be looking for? Anybody? Just me? What is the meaning of the relationship between the normal and the abnormal? Let me give you an example. Suppose you have a piece of skin, okay? And there is skin. Is there any normal tissue? Yes, it's skin. Is there any abnormal tissue? And the answer is yes. So what do you think would be the question? And then we will come back to this particular case. What would it mean, the relationship of the normal to the abnormal? Just me?
When we identify the abnormality, then we can know what pathology it is related to. Like,
No,
what's
it
the
is
cause
where is that abnormality, right? In other words, say you have the skin. Is it arising in the epidermis? Is it arising in the dermis? Is it something that is infiltrative? Is it circumscribed? All of that is about the relationship of the normal to the abnormal to the normal. Okay. Now here, will you be able to tell me, Amrita, what is since we have identified that there is a lot of abnormal here, there is also normal. Would you like to say what is the relationship of the normal to the abnormal? Because we've come to the conclusion that there is only adipose tissue that is normal, and that too is a very little bit of adipose tissue. Now, what is and there's a whole lot of abnormal. So, what is the relationship of the normal to the abnormal to the normal? What do you think? Sindhu, can you hear me, Sindhu? Yes? Sindhu, are you there? Sindhu, can you hear me? Sindhu can't hear me. All right. Pranav, can you hear me?
Ma'am.
All right. So what would you say in this case is the relationship of the abnormal to the normal? Given the fact that here, okay, we have, can you see this is the adipose tissue. All of this is abnormal. So what would you say that the relationship of this abnormal is to the normal?
there is any metaplasia, hyperplasia.
All this abnormal is actually replacing or infiltrating adipose tissue. Yes or
Adipose
no?
tissue.
Yes.
Yes,
So
ma'am.
it is an infiltrative lesion. We know this because we can see the normal, which is adipose tissue, and you are seeing the abnormal, which is diffusely replacing and definitely infiltrating adipose tissue, right? Okay, very good. Now there is a fourth question that we ask at very low power, and that question now is what Pranav had said. What is the pattern of the abnormal? All right, Amrita, what is the pattern which you can see at low power? Now, the closer you get to high power or to the cells, you can't see pattern because you lose perspective. So now tell me, what is the pattern?
I think they're
Circumscribed. Okay. What? You want to call this circumscribed? Well, all right. Sindhu has disappeared.
This
Sindhu there.
I'm here, ma'am.
Oh, you're there. All right, because you didn't answer when I last saw. Okay, Sindhu, what is the pattern of this abnormality?
Ma'am, here I can see the sheet pattern. Cells are
You can
arranged
see
in
a sheet pattern. All right. Anybody else?
Modular में
Nodular pattern.
Nodular. Who said nodular? Who said
Pawan.
nodular?
Pawan.
Pawan said nodular. Yes, I can see nodules. Can you see this? This is a
Yes, ma'am.
nodule. This is a nodule. So there is, it's infiltrative. Yes, very good. Yeah, but it is nodular. And you can see that there is a difference between what is seen in the center and what is seen at the periphery. Yes or no?
Yes.
So the center is more fibrotic. The periphery appears to be loose. It appears to show you amphophilic character. You can see that over here. So there is some amount of a myxoid matrix in these nodules, and the center happens to be a bit more fibrotic. You can see that. So there is a nodular pattern to this lesion, whatever it is. See, we don't know how this biopsy was taken, and we don't see a capsule, we don't see anything. So we don't know whether this lesion was circumscribed or not, but I can see that this has a nodular pattern at very low power. Okay, very good. So, Amrita, what are the 4 questions that we have asked ourselves? There is one more question, but what are these 4 questions?
What is the normal tissue? If there's any normal tissue, if there's abnormal tissue, what is the relation between the normal tissue and the abnormal tissue?
Very good.
Pattern.
What is pattern? Now, you know what is the last question that you ask yourself? And that is, where should I look? In which you've got a whole lot of stuff to look at. And then where should I direct my high power? That's the fifth question. So now, Amrita, where would you like to direct your high power?
I would like to direct my towards the abnormal tissues.
Yeah, that's all
nodules.
normal, Amrita.
Nodular
Everything.
area. Nodular region, ma'am.
Sorry?
Nodules.
Where?
Nodule, ma'am. Or the nodular.
Within the nodule. So you want to go somewhere here. All
Yes,
right, very good. So now let us see what we can see at. All right, here you are. That's one of the nodules which has got some adipose tissue at the periphery. All right, Amrita. Now come on. Now you have to describe this. What do you see?
I see myxoid areas and I see spindle cells
You see spindle cells and you see myxoid areas. All right.
and
What else are you seeing?
adipocytes, ma'am.
Sorry?
Adipocytes.
Adipocytes. And you see that this abnormal tissue is actually truly infiltrating adipocytes, right?
Yes.
Very good. Now, what do you see here?
Ma'am, I see adipocytes, spindle cells.
You see adipocytes. What is the most
I see a lot of vacuolated cells.
you see vacuolated cells, okay? Would you like to show me where are these vacuolated cells, please? Show me the vacuolated cells
All these cells in this region.
in this region. I can't see your mark. Oh, there. I will mark where you have marked, okay?
Yes, ma'am.
So this you're telling me is vacuolation.
Oh.
Why do you say it's vacuolation? Where is it? Inside the cell or outside the cell?
Outside
Like
the
according
cell,
to the vacuolated cells.
It's not inside.
Yeah, you know, Amrita,
Yes.
from the time that you started describing, I just want to point it out to you because what you are doing, a lot of people do. Okay, so you are actually representing a lot of the students who are listening to this. So your mistakes are very often the mistakes of the students who are listening to what you're saying. Now, 3 or 4 times you have said things and then you have retracted them. Okay, so what does that actually mean? It means that you are not actually thinking about what you are saying, Amrita. Okay,
Yes, ma'am.
you said that fibrous tissue was normal, and then you realized that no, that fibrous tissue cannot. It is probably fibrosis or it is fibrotic. Okay, all fibrotic tissue is fibrous, but all fibrous tissue is not fibrotic because fibrosis is a process. It is always abnormal. Yeah, but fibrous tissue can be very normal. There is a lot of fibrous tissue. I told you,
Yes, ma'am.
tendons, ligaments, lots of the joint capsules. There are lots of fibrous tissue that we have, capsules of organs, etc. All that is fibrous tissue, but it is absolutely normal.
Yes,
Yeah, but when I get a capsule within the thyroid, when it is a capsule of a follicular adenoma, that is not normal. Do you
Yes, ma'am.
understand? Exactly. So that is fibrosis. It is fibrosis that is forming a capsule around a follicular adenoma. This is very, very important. It's a common mistake. Now, please tell me, what kind of cells are you seeing over here? Just describe the cell.
Spindle cells, ma'am.
Spindle cells. All right. Everybody amongst you, Sindhu, Jasmi, Pranav, Dhaval, Pawan, do you all agree with Amrita that these are spindle cells?
Yes, ma'am.
Who said yes, ma'am? That was Sindhu. She's got a weak voice. Jasmi, do you agree that these are spindle cells? Jasmi?
Yes, ma'am. Spindle cells are present.
Spindle cells.
With
Pranav?
copy buttons.
Pranav?
No, sir, present one. Yes, ma'am.
Spindle cells. Okay. And Pawan? Yes, Pawan? Yes, ma'am. You think it's spindle cells. Dhaval? Fibroblasts. Achha, okay. Dhaval, is Dhaval there or has he managed to fix his? Dhaval?
No, he's not there, ma'am.
He's not there. All right. So now we don't have Dhaval. Okay. Let us see if you're right about the spindle cells. Now I can see that. Just take what is towards the right of this particular section. Okay. Do you see spindle cells over there, Amrita?
No, ma'am.
I'm going to show you a whole lot of cells. Look at them here. Okay. And then look at them in other places. Are these spindle cells? Huh? How will you define a spindle cell, Amrita? What to you is a spindle cell? Just tell me. You're used to seeing spindle cells all the time. So just define a spindle cell, Amrita.
The nucleus of the cell
Mhm.
is tapered at both ends. It is
Very good.
elongated and tapered at both
It
ends.
is elongated. That means it is at least twice as long as it is broad. And it is tapered, yes, at either end, or it may be rounded at either end or whatever. But it is an elongated nucleus in an elongated cell. Yes?
Yes, ma'am.
Now you tell me. Okay. What do you think? These are elongated nuclei, and I'm showing you that in an elongated cell. You think this is elongated over here? And then look everywhere. What does it look like? Yes?
Yes, ma'am.
It does. Okay. So if you think that that's the case, 1 second. Now look. What do you see, Amrita? What?
Spindle cells.
You
of
see spindle cells.
yes, ma'am.
Everybody sees spindle cells. I
And
don't
my-
see spindle cells. Yes, I see a few spindle cells. Is anybody writing something in the chat box? What is being written in the chat box? Are they all seeing spindle cells? So if everybody's seeing spindle cells, then because I'm not seeing spindle cells, then there's something wrong with my eyesight. There you are, Amrita. Tell me, are they spindle cells? Yeah, what's it written in the chat box? Is Devarati there or Ankita there? Is there something being written in the chat box? Ankita, Devarati,
Stellate cells.
they are stellate
Stellate
cells. Who said stellate cells? Pavan? Who? Pavan or Pranav?
Ruchi.
Ruchi, because she's reading the chat box. Very good. Those who said that these are stellate cells are right. Can you not see the processes of these cells? My God, I think we would be blind if we didn't see the processes of the cells. And then look at this. Look at these the nuclei. The nuclei have got triangular shapes. Can you see this? Triangular shapes, all kind. I'm not saying that there are no spindle cells, but the majority of these cells are not spindle. They are stellate. Okay, so why did we call them spindle? Yeah, Amrita. Why did we call them spindle? Because in your lexicon, that means in your vocabulary, you do not have stellate cells. When did you last use that term stellate cell, Amrita? When? You're describing, no, in your everyday work. Yes, Amrita?
Yes, ma'am.
11 months you have been in
11
histopathology. Yes or
Yes,
no?
ma'am.
Yeah. Did you ever use the term stellate cell? Yes or no?
No.
No. Sindhu, have you ever used the term stellate cell?
Oh, ma'am.
No, ma'am. Jasmine, have you ever used the term stellate cell? Jasmine?
Myofibroblasts.
I don't want to know what they are. Have you ever used the term stellate cell in
No,
your
ma'am.
when you are describing?
No, ma'am.
No, ma'am. Pranav, have you used this term? No. And what about you, Pawan? Pawan, have you used the term? You have. That's excellent. If somebody has used the term, then do it. Because as Jasmine says, when you actually see or you are able to recognize a stellate cell, then the thought gets into your head that I am probably looking, particularly if this is in the soft tissues, I am looking at myofibroblasts. Okay, they may be benign, they may be malignant, but you are looking at myofibroblasts. You're not looking at dendrites of a neuron. You know, these are not those kind of dendritic cells that you are seeing. Okay, but when you see this kind of cell, instead of just using this very lazy term, spindle cell, if you had noticed that these are actually just look at them. Do they look spindle cells to you, Amrita?
No, ma'am.
Do
Projections
they
we
look
have.
like spindle cells to anybody over here? And the answer is no. No, a spindle cell has got an elongated body. It does not have processes. And the nuclei, just look at these nuclei. Do they look tapered at one end? Look at them. Most of them are vesicular. Some of them are triangular. Some of them are oval. They are not spindle cells because the definition of a spindle cell is that it has an elongated nucleus within an elongated body, cell body. Okay, so you are actually seeing stellate cells, and the moment that description, that word comes into your mind, then the next thought that comes is exactly what Jasmine said, that if they are stellate cells, could these be myofibroblasts? Please, and then the next issues come. What are myofibroblasts? What are they doing in this lesion, etc., etc. Okay, good. Now look at them. Are you going to argue with me that these are not stellate cells, Amrita?
No, ma'am.
No, you're welcome to argue. I'm very happy if people argue. But just look at these. So, with their the cells are triangular. They are all kinds of shapes. They have these elongated processes that are coming out of the cell body. So these cannot be spindle cells. Spindle cells do not have processes. Please. All right. See, I'm just showing you more and more. Now, all of you should have seen this. Amrita, had you seen
Yes, ma'am.
it? You did. And if you call them spindle cells, then obviously you had a whole lot of other things in your differential diagnosis. All right. So what was your diagnosis, Amrita?
Myofibroblast.
Sorry?
Ma'am, I'm not able to.
What was your diagnosis when you saw it?
Ma'am, myofibroblast.
Okay, myofibroblast. Okay, good. Anybody else have any other thought on this? Pavan, what was your diagnosis?
Keloid.
Epithelioid.
Keloid.
Okay, why do you think it was epithelioid, Pavan? Huh?
Keloid.
Keloid. Acha, keloid. All right. Pavan thought it was a keloid. Pranav, what did you think? Oh, you had no answer. You didn't know what it was, Pranav? All right, Jasmine?
Fibromatosis.
Fibromatosis. All right. So we have myofibroblast, don't know what it is. Then we have keloid, we have fibromatosis. Okay. And Sindhu?
I could see some storyform appearance of
So, storyform appearance. All right. Where did you see the storyform appearance?
arrangement of the.
No, I know what storyform is, but where did you see it? Do you think this is storyform?
Uh,
Stop me where you think it is storyform. Do you think this is storyform?
yes, ma'am.
Yes. Well, who agrees with Sindhu that this is storyform? Jasmine, you agree that this is storyform? Yes or no? Just say yes or no, Jasmine. Is this storyform?
Hello.
Jasmine, I can see you. So, is this storyform? Jasmine's gone. All right.
Ma'am, it's not storyform.
It is not. Will you tell Sindhu why it is not storyform?
Storyform is like one above the other. Cartwheel appearance.
Storyform is what? Sorry, Jasmine. One above the other.
Cartwheel appearance.
Cartwheel appearance. Okay. Just do one thing. Just ask for annotation. Both you and Sindhu, ask for annotation. All right. This is yeah. Okay. Now draw anywhere on this thing. Sindhu, what do you think is story form? And Jasmine will tell you what she thinks is story form, which is not here. Yeah, come on, Sindhu, why do you think that this is story form? Where is the story? I see a red line.
The arrangement of the cells are interlacing with each other.
No, I don't want you to define it. I want you to show me the story form. Come on. Come on, Sindhu.
Yes, ma'am.
Just draw an area around where you think is story form. What? Yours is green or yours is what color?
Red, ma'am.
Red. Okay. And whose is green? So what is this? You've just drawn some lines. So what? Where is the story form? Now, if I were you, I might want to say that after all, what is story form? Story form is a point, yes, somewhere, and from that point you get this kind of appearance. In other words, sometimes it's like that. Sometimes it is like this, and then like this, and then from another point like that, and from this point like that. Do you see anything like that at all? And the answer is no. You're not seeing a story form pattern over here. What you are seeing, all of you, is a haphazard pattern. There is no pattern at all. Okay, so if you think that there is a story form pattern over here, there is no story form pattern. Okay, see, let me tell you. See here, if you had said that this is the cartwheel in the sense, here is the center, and I can see something going like that. Sorry, something going this direction, or I think I got myself into a mess. One second. Okay, like this, and something going out like this, and something going out like that, and something going out like this. Okay, I might have agreed, but it is not a story form pattern. Okay, so please, there is no story form pattern in this thing at all. So because you saw a story form pattern, what is it that you wanted? What was your diagnosis? Yeah, Sindhu, what was your diagnosis because you saw a story form pattern? Come on, Sindhu, you had a diagnosis, right? So what was your diagnosis? Everybody has given their diagnosis, so what was yours? You don't want to share your diagnosis with anybody, Sindhu? What was your diagnosis? You're muted, Sindhu. Please unmute yourself. So what was your diagnosis? Sindhu, I can't hear you. All right, it doesn't matter. Now, we have got at least 4 diagnoses over here, okay? Number 1 was Anita, who said that these were just myofibroblasts, but she didn't know what else it was, okay? So let us come to the observations and the interpretations. Then we had somebody who said that this was fibromatosis. Then we had somebody who said that it was, sorry, Pawan, what did you say? A keloid. So we had a keloid, we had a fibromatosis, and we had myofibroblast. Anybody else had anything else to say? Yeah, Pranav, you didn't know what it was, right? Fibromatosis. Okay. And Pawan said what? Keloid, right? Okay, Sindhu didn't say anything. So what is the principal cell in the lesion? I think all of you know what this principal cell is. What is it? By now. Yeah, Amrita, what is it? It's a myofibroblast, right? Very good. So the principal cell in this lesion is a myofibroblast. All right. Did you notice any other features apart from just the cell being myofibroblast? And I've shown you.
Myxoid background.
Yes.
Myxoid background.
There was a myxoid background. Very good.
RBCs.
There were, yeah. So somebody said RBCs.
RBCs.
Yes, you can see RBCs that are present here that are extravasated. Excellent. Yes. Who said that?
Ma'am.
Amrita?
Yes, ma'am.
Very good. So I just put down all these features: nodular, well-defined lesion in adipose tissue, infiltrative edges, central. The word is not fibrinous; it should be fibrous areas. Virtually no inflammatory cells. Did you see any inflammatory cells? And the answer is no. There were extravasated RBCs, loose connective tissue. That's why you had what looked like a myxoid connective tissue, and irregularly placed collagen. You can see all of that over here. So now, what is the lesion? Somebody who said fibromatosis, right? Why did you think it was fibromatosis? Who was that now? That was Pranav? Yes. So can you tell me why it is fibromatosis? Which fibromatosis? Desmoid fibromatosis? Yeah? Yes or no? Well, a fibromatosis is a densely collagenizing lesion, all right? Now, do you think that this is a densely collagenizing lesion, Pranav?
No,
The answer is no. It is largely loose and there is a myxoid stroma. The moment you see myxoid in a lesion, it cannot be fibromatosis. Have you got that right? Okay, the same argument is for keloid. A keloid is like a hypertrophic scar. And what is present in a scar, Pavan?
Healing fibrosis.
Fibrosis, dense collagenous fibrosis. You think this is densely collagenized fibrous tissue?
No.
Yeah, Pavan?
No, ma'am.
No, ma'am. So making a diagnosis of a keloid is not correct. Okay, Jasmine, you also thought it was fibromatosis, right?
Yes, ma'am.
Yeah. So now you know it cannot be fibromatosis because fibromatosis is a collagenizing myofibroblast lesion. Yes, fibromatosis is a myofibroblast lesion, but this is loose. This is got myxoid tissue. There is some central fibrotic lesion, but it is not all over collagenized. So it cannot be so. So now what is left as the diagnosis?
Nodular fasciitis.
Yes, there you are. It is nodular fasciitis. Okay, now you tell me over here. What is the most crucial decision in this decision-making tree? Do you know that we have a decision-making tree just as you have the 5 questions that you have to ask on local? This is one of those decision-making trees. Is it congenital or acquired? Whatever the lesion you're seeing. Is it physiological, pathological, neoplastic, non-neoplastic? If it's neoplastic, is it benign or malignant? If it's malignant, is it primary or secondary? And then if it's non-neoplastic, it has to be one of these conditions that is in the blue box. And finally, you make a diagnosis. So now, Amrita, tell me, which is the most crucial decision that you have to make on this decision-making tree?
Physiological or pathological?
Physiological or
Neoplastic.
pathological? Do you think that this could be physiological?
Neoplastic or non-neoplastic?
So is it neoplastic or is it non-neoplastic? All right. So now what do you think?
Neoplastic.
You think it's neoplastic. Why do you think it's neoplastic? Why do you think that nodular fasciitis is, because that's what you said it was, right?
Yes.
It's neoplastic. Is it neoplastic? Let me ask any one or the other. Sindhu, is it neoplastic?
It is a benign tumor.
It's benign, right? And you think it's a benign tumor. All right, Jasmine,
It's benign.
I know it's benign, but is it a tumor or is it not a tumor?
A tumor.
It's a tumor. All right, Pranav, is it a tumor?
Nine tumor.
All right, and Pavan?
So it's a benign tumor.
Benign tumor. All of you think that it is a tumor. All right. Now the question is it neoplastic or non-neoplastic? Now you know the neoplastic tumors. What do we call them? Myofibroblastomas, myofibrosarcoma. All right. And the non-neoplastic ones are the reparative tissues, which are reactive proliferation. So where does nodular fasciitis fit, Amrita? Well, it fits in between the neoplastic and the non-neoplastic. All right. The diagnosis is in this short duration and rapid growth. Okay. Because you have a short duration and rapid growth, it's very unlike a benign tumor, isn't it? Benign tumors usually do what? They have a long duration of etc. So this is where nodular fasciitis fits. For a long time, we believed that nodular fasciitis was a non-neoplastic condition. Today, we are not sure whether this is neoplastic or this is non-neoplastic. Some of you who have said, all of you who have said it's neoplastic may be right. All right, because there has been a kind of a rearrangement that has been found. It is a recurrent translocation, which is called the T1722 translocation in many nodular fasciitis. Okay, but not in all. But nonetheless, you might say, because there's a translocation, this must be a tumor. But is that how we actually define tumors? Because this lesion is self-limiting. It disappears. You don't see the nodular fasciitis. Once it reaches its full growth potential, then it regresses. So now, is there some peculiar kind of tumor that grows and then regresses? Yeah, we know that there are tumors that grow and regress. There are things like neuroblastomas that grow and regress. So is it that kind of neoplasm, or is it just a kind of a reactive process which happens to have a translocation? I don't know the answer to that question, but you should know that there is a recurrent translocation that is seen, which you see over here, which involves the USP6 gene activation, and it is a T1722 translocation. And there are many similarities between nodular fasciitis and young scar tissue. See, I'm showing you young scar tissue on your left, which is a post-lumpectomy scar. And you can see similar features as you see there on the nodular lesion that you see on the arm. Okay, this is a small lesion that is seen in the post-lumpectomy scar. This is a larger lesion, but the cells are exactly the same. All myofibroblasts produce a myxoid stroma, which is a pre-collagen. If you want to call it that way or to remember it that way, it's mesenchymal mucin, which then gets converted into collagen. So you see that here. You see this young fibrous tissue in a lumpectomy scar, which is now becoming more and more fibrotic, and that scar will contract, and ultimately you may not see the scar in the soft tissue again. So if somebody didn't tell you that this was post-lumpectomy, you see everything that you would otherwise see in a nodular fasciitis. Okay, and I always tell students, you want to know what a nodular fasciitis looks like, then go study, a young scar. You can do it in post-lumpectomy. You can, if somebody happens to revise some kind of tissue which is on the skin in which you see a young scar, you'll be able to see that. So that is how a nodular fasciitis looks like. On the other hand, for Jesse and I think it was Pranav and see this is desmoid fibromatosis. Okay, on the left, and this is a well-healed scar on the right. Okay, this is a scar. I knew that there was surgery before and it's a scar. And you can't see the difference between a desmoid fibromatosis on histology and a well-healed scar. So what is the difference? There is no difference in morphology. It is that I know what was the inciting factor in the scar, and I don't know what is the inciting factor in the desmoid fibromatosis. But those who thought that this particular lesion that we have called nodular fasciitis is a desmoid fibromatosis, please imprint this picture in your head. It is got no myxoid change. There are myofibroblasts because both of these, including scar tissue, has myofibroblasts. But that does not make each one is nodular fasciitis, the other is desmoid fibromatosis. It is the amount of collagen that is present in desmoid fibromatosis and the amount of myxoid that is present in nodular fasciitis. Do you get the picture now? Are there any questions? Are there any in the chat box? Any questions amongst you five? No, Amrita, any questions? No. All right. I'm not going to approve this annotation. Dr. Dash, I think you have pressed that little squiggle on the top right-hand side of your screen. Please don't do it because then you're asking for an annotation. Okay. All right. Any questions in the chat box?
No,
Devrati?
No, ma'am.
Ankita?
Okay, just now there is a question.
Yes,
Is
all right.
sprinkling of lymphocytes necessary?
Sorry?
Is sprinkling of lymphocytes necessary?
No, it is not. Not at all. You may or may not have any lymphocytes or any other. In fact, if you see a lot of lymphocytes and ask yourself a question, is this a young scar? Okay, because that's where you actually see it. If you see a few lymphocytes, it doesn't rule out nodular fasciitis, but not seeing the lymphocytes doesn't make it something else or whatever. You don't need them. Okay, good.
One more.
Yes, what is it?
Whether nodular fasciitis is neoplastic or non-neoplastic?
Well, I think I said that very clearly. We don't know for certain. It was for a long time believed to be a reactive condition. The inciting factor for that, we didn't know. So that it was just something that came up. And we still don't know whether it is neoplastic. Although, as I told you, there is the translocation of that USP6 gene that is seen in a large number of cases of nodular fasciitis. And if you are of the view that if you have clonality, if you have an abnormal gene, it makes it malignant. Or sorry, not even malignant, but it is neoplastic, then you may think it's neoplastic. I do not believe that having an abnormal gene is or abnormality in the genome of a particular lesion makes it neoplastic. Okay, now that's not a discussion that we can have today. So I cannot answer the question whether nodular fasciitis is or is not neoplastic. Okay.
I also have questions.
Who is this?
Antonella.
Yes, Antonella.
Regarding the myxoid stroma, from what I know, a myxoid stroma has a bluish appearance and it's referring to something containing mucus-like, so bluish appearance. And
Yes.
that's what I know. And I didn't quite see a bluish stroma in the tumor, so
Well, Antonella, you are seeing a bluish stroma.
Okay.
You don't think that this is a grayish blue stroma? Do you think it's all pink, Antonella?
It's not a bright pink. It's not like collagenous stroma. But
Then what color is it? What color is all this, Antonella?
it's more pale.
Pink, Antonella.
Pale.
It's pale. So pale
Pale.
what? Pale pink or pale blue?
Yeah,
Pale
pale.
what?
Pale pink.
Really?
From
Everybody thinks that this is pale pink? To me and to everybody else over here, Antonella, it's pale blue. You can see that. This is grayish blue. What's in this, where you see my cursor going? This is mixoid. And Antonella, you should fix that that thing in your mind, okay? It depends on the tinctorial properties of how something has been stained, but this is certainly not pink. This is bluish gray. And if there is anybody who would like to sort of agree with me or agree with Antonella, please put your question in the chat box, okay? Or your agreement or not, as the case may be, in the chat box. Antonella, this is mixoid. All right.
And there's one more question.
Yes, please.
Desmoid fibromatosis develops after cesarean scar also. Then how to differentiate it from well-developed scar?
Well, it's a very diffuse lesion. It's not like a scar which is linear, okay? Like a keloid. It is a diffuse lesion. It actually forms a mass. So that's the difference between any fibromatosis and a well-developed scar. So I hope that answers the question. People don't come up with just a little keloid like that, or something that it is a scar that is it is a mass that is diffuse and very infiltrative. Okay.
Thank you.
All right. So now let's go to the next case. Who would like to take this case? Jasmine? Jasmine, are you there?
Yes, ma'am.
Yes, come on.
A 67-year-old male patient endoscopic submucosal dissection of multiple polyps in the stomach.
Yeah. Okay. Good. Jasmine, does anything come to your mind when somebody's talking about multiple polyps in the stomach? We know what we think when there are multiple polyps in the colon, right, Jasmine?
Yes, ma'am.
There can be several different things. When you hear of multiple polyps in the stomach, what comes to your mind, Jasmine? Anything comes to your mind? What? Do you think that this is now part of, or do you consider that this patient must be having adenomatosis, polyposis coli, and was also involving the stomach and the maybe even the duodenum, etc.? What does multiple polyps in the stomach make you think?
Would be a hyperplastic polyp.
Hyperplastic polyps, okay. Are they usually multiple?
No,
They may
ma'am.
be. All right, okay. So let's go on now to this. What do you see here, Jasmine?
Ma'am, ball of stomach. The normal,
When you say ball of the stomach, yeah, you're asking yourself some question, right? What are the questions
Yes,
you're
ma'am.
asking, Jasmine?
The normal tissue.
Is
So
there
ma'am,
any
it's
normal tissue? Yes, and what's the answer?
Yes, ma'am. It's lined by the glandular mucosa with columnar.
Okay. So
Then,
your stomach, that's what you want to say, right?
yes,
It is
ma'am.
stomach mucosa.
Yes, ma'am. Stomach mucosa, and then the laminar propria with the muscularis mucosa is also seen.
Yes,
In the
excellent.
submucosa,
And you see the submucosa. Excellent. Very good, Jasmine.
yes. And then in the submucosa, there is a growth, a lesion,
There is a lesion in the submucosa. Okay.
which is extended.
So you've
Just-
answered question number 2 and 3. Yes?
Yes,
What
ma'am.
is the question number 2? Is there any
question-
abnormal tissue, right?
Yes, ma'am.
And you said that yes, there is abnormal tissue, and the relationship of the normal to the abnormal is that
It
you
is
can see that abnormal tissue sitting
in
in
the
the submucosa. Okay?
Yes.
That's what you can see at this part. Jasmine,
Yes,
this particular, the middle section. Yes, Jasmine, does it remind you of
Yes.
something? And I don't mean pathological. These two, actually, do they remind you of something? I'm asking because you're a lady, Jasmine. Then I'll ask Sindhu and I'll ask Amrita. Does it remind you of some pattern that you have seen anywhere?
Seahorse.
Yes, Amrita?
Seahorse.
Seahorse. Acha. That's what you think, all right? It reminds you of a seahorse. I'm asking you because you're ladies, which means what? What does it remind you of? Antonella, are you there? Or has Antonella been, has she been muted? You know what it reminded me of? This. That's why I said that we are ladies and we should think about this. No, it's the Paisley design, which is sometimes, I think it's nice when you are looking at things to imagine, the different kinds of patterns that we see in nature or we see in some of our designs that are on our clothes, etc. And this is a Paisley pattern, which is an ornamental textile design. We often call them buttas, which we say that we have buttas on our saris and other things where you have either a print or you have a embroidered something or the other. But it's interesting that this design came from Persia. And we have used this, came from Persia through the Mughal Empire, and a number of shawls and different textiles from Kashmir show you this pattern. It's called the Paisley. It's nothing to do with our diagnosis. When I looked at it, I said, hey, this looks like a Paisley pattern to me. All right, Chalo, now come on. Who's doing this? Jasmine.
Yes, ma'am.
Come on, Jasmine.
So, ma'am, it is seen in the submucosa, and
It is seen in the submucosa.
Yes. there's a fairly circumscribed lesion in the submucosa.
Uh-huh. You've seen this before, haven't you, Jasmine? Did you see this before you came to this slide seminar? Were you able to see it when it was posted on Telegram?
No, ma'am.
You didn't? You didn't know it was posted on Telegram? No, Jasmine, very good. If you didn't see it, then you're looking at it for the first time. All right, very good, Jasmine. So you're seeing something that seems to be situated in the abnormalities in the submucosa. Can you make out anything about the abnormality? What's the pattern? Because now we come to question number 4. What's the pattern? Yes, Jasmine?
Ma'am, there's collagenization, there's collagenized stroma, and also some gland-like structures inside.
Gland-like structures. All right, very good. But do you think, Jasmine, that it is only in the submucosa? You didn't see this, unfortunately. But anyway,
In the laminar propria.
it is actually both in the laminar propria
Laminar propria,
as well as in the submucosa. Anything else you would like to say about the relationship of the normal to the abnormal? You are right. You can see that this is in the laminar propria here. Yes.
Yes, ma'am.
As
Yes,
well
ma'am.
as in the submucosa. Anything else you'd like to say? what is normal over here?
There is lymphocytic infiltration in the lamina propria, which is
Right, that's
not present in normal stomach.
All right,
It
excellent.
makes
So where do you think that this is arising from? I mean, is it arising from the epithelium or is it not? It's in the lamina propria,
be
absolutely.
from the epithelium, not because of the glandular.
Because it is glandular, it is arising from the epithelium. Now, Jasmine, look carefully at this epithelium. Yeah, you recognize it as the stomach. Is it the stomach, Jasmine?
Goblet cells are present, ma'am.
So
There is metaplasia in this.
so this is, if this is the stomach, you're absolutely right that there is goblet cell metaplasia, which suggests that there is intestinal metaplasia. Yeah. Yes, excellent. Do you think that this is stomach or is this colon or is this small bowel?
This is stomach only, ma'am, because of the it has got a crypt-like and then the fovula is also there.
Sorry.
The fovula
Yes, there is
epithelium
foveolar.
is also there.
Yeah. Would you like to show everybody where the foveolar epithelium is? Jasmine?
Yes, ma'am.
Yeah, okay, good. Now show everybody where the foveolar epithelium.
This one, ma'am. This.
Yeah, Jasmine is absolutely right. This is surface epithelium of the stomach, which has got a completely different appearance from, it does not have goblet cells. Okay, so this epithelium is normal foveolar epithelium of the stomach, yes, and it does not have goblet cells, which is what tells you that this is not small intestinal, nor is it a large intestinal mucosa, because you do not get this kind of foveolar epithelium in either the small intestine or in the large intestine. That's excellent, Jasmine. All right, so you have got intestinal metaplasia in the stomach over here, yes. Do you know what might accompany intestinal metaplasia in the stomach? See, there's lots more foveolar epithelium. You agree? Okay.
Yes, ma'am.
Oh, excellent. Now here is you can see where my cursor is. That is the muscularis mucosae. Right, Jasmine?
Yes, ma'am.
Now what should occupy the space between the gastric pits, which is the deepest part of the foveolar epithelium, and the muscularis mucosae? What should occupy that space, Jasmine?
The lamina propria with gastric glands.
Lamina propria with gastric glands. Do you see gastric glands?
Yes. No.
Do you see gastric glands? Jasmine?
Yes.
Can you?
No.
No, ma'am.
No,
Anybody
ma'am.
see gastric? Yes, they are there. The gastric glands are there.
Yes, ma'am.
Here are the gastric glands. Okay. These are not gastric glands, but they should be all the way down, reaching the lamina propria, right? But they're not there. In many places, there are no gastric glands. Do you see that, or you don't, Jasmine? There are no gastric glands at all. Okay. Well, I don't know what. So something has happened to these gastric glands. Now the glands are so few, or they are none at all. So what is that condition, Jasmine, in which you have no gastric glands at all?
In
Yes,
atrophic gastritis.
it is atrophic gastritis. Absolutely right. So you have got gastric mucosa with atrophic gastritis, and you can see that there are very few gastric glands at all. You've got the foveolae going all the way down, and there are no gastric glands that are there. Now these few gastric glands that you see over here look like mucus secreting gastric glands, which you would expect, say, in the antrum of the stomach. Okay, so that is almost like the pylorus of the stomach. Okay, very good. Jasmine. Anything now when you look at this and you see these, you're going to call them. Now, do you see something here now, Jasmine? What do you see in this? We'll come to the main lesion a little later, but what are you seeing here?
Ma'am, some eosinophilic cells.
There are eosinophilic cells. Excellent. What are they? What are all these?
They're oxyntic cells, ma'am.
They're
Eosinophilic cells.
oxyntic cells. That's absolutely right, Jesse. So you are seeing this part of the stomach, or this part of this resected portion of the stomach, is showing you oxyntic mucosa. Yeah, because you have long gastric glands with these. These are the glands. These are the foveolar pits. Okay, and this part of the stomach looks fairly normal because you have. These gastric glands are not atrophic. Do you agree, Jasmine?
Yes, ma'am.
Yeah. The rest of these are showing intestinal the rest of this section shows intestinal metaplasia, loss of gastric glands. There are no gastric glands. So what is replacing these gastric glands now, Jasmine? Now there's something, no? Which is replacing all of this. So would you like to describe that? Yeah, Jasmine, what is replacing it? What are all these things? These are there is something that is present in the submucosa as well as in the lamina propria, and it seems to be replacing these gastric glands. There is atrophic gastritis, without a doubt. It's with incomplete intestinal metaplasia. It's very patchy. There is some residual gastric glands, but the rest of the gastric glands are gone. So there is gastric atrophy. There is inflammation. So there is chronic gastritis with gastric atrophy with intestinal metaplasia, with at least in this particular section, looks an incomplete intestinal metaplasia. And in the lamina propria, as well as in the submucosa, you see something. So would you like to describe that?
Probably some neoplastic cells, ma'am.
You are seeing neoplastic cells. Why do you say that it's neoplastic? Why don't you just describe them? What are you seeing?
Ma'am, some cells, they are seen in clusters, they are seen in glandular pattern, abundant eosinophilic cytoplasm, round to oval nucleus, and hyperchromatic chromatin.
All right. Jasmine, you said something about glandular. You've been saying that from the beginning. What is what is a gland, and how does it differ from a duct, a tubule, an acinus? Jasmine, you know that we use these terms, right? We say acinus, we say duct, we say tubule, we say ductule, we say gland, acinus. So now tell me, why did you pick the term gland? Any reason, or you think that they are all interchangeable? Sometimes I'll say gland, then sometimes I'll say acinus, sometimes I'll say tubule, sometimes I'll say ductule, duct, what?
I mean cells arranged around a central space.
Yeah, so is an acinus not around a central space? Duct is also around a central space. A tubule is also around a central space. Yes, Jasmine? So what would be the difference?
If there could be secretory like any mucinous lining or anything, then we can call it.
Jasmine, if you have the lining around the central space, and you're absolutely right, is secretory, yes, and that is secretion is being poured into that space, then you call it a, what would you call it, Jasmine?
Glandular.
Gland. But that's not true of a duct. A duct is merely a conducting space, right? Yeah.
Yes, ma'am.
So it is a function that tells you the difference, and it's important for us to know, because if we keep on saying gland, all right, we sometimes miss the the bigger picture, because our mind is not thinking. Like we said in the first thing, if we all said that they were spindle and we did not recognize that they were stellate, then we sometimes would miss the fact that these were myofibroblasts. So if I use this term gland non-specific in a non-specific manner, then I might miss something about what it is that I should be thinking about. Okay. So now, do you want to say gland, Jasmine? Now look at it. You can see some of it over here. Yeah, you can see some of it.
Yes,
Over here. Now,
These are
do they look like glands to you?
Yes, ma'am.
They do what? You know that this is what you're seeing. Yeah, this is a gland, definitely, and that is a normal gastric gland, Jasmine. Yeah.
Yes.
Okay, but do you think that these are glands? What do they look like to you over here? We'll go to look at it. I'm now looking at it in the lamina propria. So, does it look secretory to you, Jasmine?
Don't look secretory, ma'am.
They don't look
Clusters of
secretory.
cells.
Excellent. So, if I had to describe these formations, these patterns, what would I describe them as?
Clusters of cells, ma'am.
Clusters, very good. Any other
Any trabeculae.
trabeculae? Perhaps not. Yes, they are clusters. They are islands, right? They are nests and they are islands, because cluster is a very non-specific thing. The moment you say cluster, your mind has just not zeroed down on a thought. It just means, okay, there are cells that are together. You say nest, you say island, and some other thought comes to your mind. All right, very good. All right, you said islands and nests. Now, Jasmine, tell me, what would you say about the morphology of the cells that are forming these nests and islands? And what is their relationship to the normal foveoli and the gastric glands?
Ma'am, they are kind of monomorphic cells.
Excellent. Very good, Jasmine. I think Jasmine is doing extraordinarily well. Yes, Jasmine, they're monomorphic. And
With moderate cytoplasm. ma'am.
moderate cytoplasm, very good.
And then round to nuclei, right? Round to.
Have you finished with the cytoplasm?
Eosinophilic.
Eosinophilic, yes. Cytoplasm. Yeah, really, yes. It's eosinophilic cytoplasm. Wherever you can see detail, you will see that the cytoplasm seems to have some kind of borders. No, you can't see it very well over here, but okay. And then you have the round, very round nuclei.
Nucleus.
Yes. And anything else you want to say about those nuclei?
They look hyperchromatic, ma'am.
Okay, they're hyperchromatic, but in other words, they're dense, no? It's not hyperchromatic. They are dense nuclei. So the nuclei are not vesicular. They are dense.
Dense.
Otherwise, you would call the nucleus of every lymphocyte hyperchromatic. We don't call it that, because hyperchromasia means that it is more blue or it's taken on a deeper stain than normal. Now, we don't even know the normal counterpart of these cells. At least we can't tell it from just looking at this. Am I right, Jasmine? Yeah,
Yes,
so you just say it's excellent, it is monomorphic, it's pink, the cytoplasm has got a nice pink color, and I think you can see that these are cuboidal cells, and they are in nests, and they are in islands, and you can see these rather dense nuclei that are sitting, at least in this instance, sitting in the center of the cells. All right?
Yes.
Now you see that here is just large amounts of intestinal metaplasia, right? Okay, so this is atrophic gastritis, intestinal metaplasia, and then you are beginning to see these. You saw them in the upper part or in the mid part of the gastric mucosa, now you're seeing them here. And here you might feel that these are forming small tubules. You see them?
Tubules. Yes, ma'am.
Okay, this is just to show you that there is a lot of intestinal metaplasia that is there. Now come. It's the same cells. Do you agree with me, Jasmine?
Yes, ma'am.
So they are the same cells. They were in nests, they were in islands, large and small. You call them clusters. Yeah, that's fine. But what are they looking like over here, Jasmine?
Look like tubules, ma'am.
They are tubules. Now you see, they are not glands. They are forming tubules. You might want to call them acini if you wish, but these are not glands. Okay, so these are cells which look exactly similar to the cells that we saw in the lamina propria. They are sort of, if you wish to say, infiltrating through this muscularis mucosae into the submucosa. Now you might say that maybe it's from the submucosa up into the lamina propria. Whichever way, I don't think that, but both the lamina propria and the submucosa have it, and the muscularis mucosae has been infiltrated by these cells. And once again, the cells they may be forming small and medium-sized tubules, racini, whatever you want to call them. They're also in cords. Can you see them?
Yes,
There are multiple patterns here.
Cords, yes,
You've got nests, you've got islands, you've got cords, you've got small tubules, and the cells are monomorphic. That there's no doubt about. The fact that the cells are monomorphic, but they are forming multiple different patterns that you can see over here. Now you see this?
Yeah.
Again, they are in these. There is no secretion in any of these things. There is some, I would say, maybe some kind of grayish material there, but they're not really secretions of any particular kind. But monomorphic cells forming tubules, irregular tubules, and acini. Okay, Jasmine, is anything coming to your mind now? What are these cells? Do you think that they are? Well, yes, they are neoplastic. I don't think that anybody would disagree that they are neoplastic. But what are they? Does it look to you like this is some kind of carcinoma of the stomach because it is sitting right there in the stomach? What would you say, Jasmine?
Could be actinoma.
Sorry?
No.
They are bland monomorphic cells in many different patterns. No, all right. And Jasmine, you didn't you didn't have a chance to study it, and therefore you did excellently for somebody who hasn't studied these, these cases. So anybody else now? Pranav, did you study this? You saw it in Telegram or not, Pranav?
No.
Are you there, Pranav? Pranav's disappeared. Pavan,
I didn't see in Telegram.
you did or you didn't?
I didn't.
You didn't. Why? You didn't know that it was going to be put up on Telegram?
It was not. No, it was not. It was like WhatsApp. It was like they're not able to share the PPT.
You were not able to share it. What about Pawan? Pawan, did you see it?
No, no, ma'am.
So nobody saw these slides.
No, ma'am.
Nobody. That's very sad because it was put up on there. Amrita, did you see it?
No, ma'am.
So nobody saw it. And that's Shrutika said that she was going to put it up on Telegram. I don't know what happened, but anyway. So all the better. So now you guys have to make up your minds over here. All right. So now, what is the principal cell in the lesion? Come on, any one of you. Amrita.
Neuroendocrine.
Sorry, yes. What did you say, Amrita?
Neuroendocrine cells.
Neuroendocrine cell. All right. Amrita thinks it's a neuroendocrine cell. Sindhu?
Same neuroendocrine cells.
Neuroendocrine cell. Very good. Jasmine, do you think it's a neuroendocrine cell?
Yes, ma'am, possible.
Possibly.
Monomorphic.
Exactly. Pranav, what do you think? Pranav? I don't know. He goes off the thing. Pawan?
Yes, ma'am. They look like neuroendocrine.
They look like neuroendocrine cell. Yes. So the principal cell in the lesion is a neuroendocrine cell. So what are the other features that you noticed, Jasmine, apart from the fact that there you saw neuroendocrine cells that were in all the patterns that we described in the lamina propria and in the submucosa? So what other features did you notice? Because you mentioned them and you did that very well. You saw neuroendocrine cell hyperplasia. You saw these tiny little groups of neuroendocrine cells in groups, in acinar formations, infiltrating the submucosa in a nodular and diffuse fashion, and there is atrophic gastritis and incomplete intestinal metaplasia, right?
Yes.
That's what we saw. Okay, very good. So these neuroendocrine cells are ECL proliferation. ECL is, what is it, Jasmine?
Ma'am, enterochromophene-like.
Yes, so enterochromophene-like cells, which are present in the gastric mucosa. And then you can have linear hyperplasia, nodular hyperplasias, and if the nodules are larger than 5 centimeters, then and limited to the mucosa and the submucosa, they're called, you know that these can then be called a neoplasia. So neuroendocrine cell neoplasia. So we've seen everything, all of these in this. I've just cancelled out that dysplasia because nobody uses that term at all. This was some old criteria in which dysplasia was mentioned. Right, okay. So how can we prove that these are neuroendocrine cells, Jasmine?
Markers. Like synaptophysin.
What markers?
Synaptophysin.
Synaptophysin and chromogranin. Excellent. So now on the first thing on the left-hand side, yes, what is this marker, Jasmine?
It's nuclear, ma'am.
Sorry? No, it's not nuclear. No. These are, you can see that the nuclei are...
Membrane, ma'am. It's membrane positive.
Well, it's cytoplasmic as well as membrane. So tell me, what do you think, what marker is this?
Synaptophysin.
Synaptophysin. All right. Amrita, what is it?
I think it's a fancy cytokeratin.
I think it's cytokeratin. All right. Let's ask Sindhu. What is this? Sindhu?
Yes, ma'am.
Yeah, what is this left-hand side? Please let me know what they're saying in the chat box. Devarati.
Yes, ma'am.
So Sindhu, what do you think it is? We have two things here. Jasmine thinks it is synaptophysin and Amrita thinks that it is cytokeratin. So what do you think, Sindhu?
Cytokeratin.
Cytokeratin. Okay, Pranav? Pranav never answers. He takes forever. Pawan?
Synaptophysin.
Synaptophysin. All right. So now at least out of those who answered, I've got 2 synaptophycins and 2 cytokeratin. Jasmine, you want to tell them why you thought it was synaptophysin? Then I'll ask Amrita.
Ma'am, the tumor cells have also taken up the cytoplasmic
Tumor cells have taken cytoplasmic thing.
and membranous positive.
All right. Is it only the tumor cells that have taken it up?
No, ma'am.
No. What else has taken it up?
The foveolar cells.
Right. So now, do you think foveolar epithelial cells, every single one of them, would take up synaptophysin? Jasmine?
No, ma'am.
No, ma'am. So now, Amrita, would you like to tell Jasmine why you said cytokeratin and Sindhu also said the same?
Because the foveolar cells have also taken it, all the cells have taken it, and also the neoplastic cells have taken it.
Right. So every cell in that gastric epithelium, as well as the neoplastic cells, have taken up whatever this marker is, the stain. And it's looking brown because we have what have we used, Jasmine? This is immunohistochemistry, right?
Yes, ma'am.
Right. So why does it look brown? Why does it look brown? Jasmine? No? All right. Amrita, why does it look brown? Why does the stain look brown? Amrita, are you there?
Yes, ma'am. Yes, ma'am.
So why is it looking brown? This is immunohistochemistry. Why is it looking brown?
Yeah.
Okay, Sindhu, why is it looking brown?
Because of the secondary tab chromogen.
Because of the chromogen. So what chromogen are we using?
Tab, ma'am.
That.
DAB. What is DAB?
Diaminobenzene.
Diaminobenzene. Okay. So what is the color of DAB?
Brown color, ma'am.
Really? The DAB is brown? Do you do immunohistochemistry in your labs?
Yes, ma'am.
Yes, you do. All right. Have you ever seen DAB?
Yes, ma'am. I have seen.
And it looks brown?
No, ma'am. It is colorless.
It is colorless. So how did it become the chromogen? You said it's a chromogen. How did it become brown? How did it become brown, Sindhu? Pawan? How did it become brown? So now there is something that all of you, we just say brown, right?
Peroxidase.
So there is peroxidase in the system, and that peroxidase is conjugated to a polymer, which is conjugated to the secondary antibody. So wherever the secondary antibody is, peroxidase is there. And when you add DAB, okay, DAB is the substrate of peroxidase, and that turns the DAB into a colored compound. And that's why you see it as brown. Please, just don't look at things and say, oh, it is this and it is that, it's brown. I could make this red, right? I can use a different enzyme that is conjugated to the secondary antibody through polymer or whatever other means, and that can be alkaline phosphatase, and then I put the substrate for alkaline phosphatase, and this whole thing will turn red. So it's not, there has to be some kind of understanding of what is going on. Anyway, so this cannot be synaptophysin. Do you agree, Jasmine?
Yes, ma'am.
Okay, so this is pan cytokeratin. Very good for Sidhu and Amrita. So what is the next one, Jasmine? What do you think? You see the middle?
Yes, ma'am.
So what is it?
The next, this could be some.
It's immunohistochemistry. So can you guess what immunohistochemistry has been applied there? The middle.
This is a cytoplasmic gram, so mostly synaptophysin.
Synaptophysin. Yes, it could be synaptophysin, it could be chromogranin, it could be any marker that will mark the neuroendocrine cell. Yes. So this is synaptophysin or chromogranin A. Now, what about the last one, Jasmine?
It is a nuclear, ma'am.
Yes, it is nuclear. Very good. You can make that out because you can see that it is not present in the cytoplasm of these foveolar cells. Otherwise, all fixed. If you go to the pan cytokeratin, you see everything is marked. Here, you can only see that basally you see that marking, which means, and it is dot-like, so it must be nuclear. So what could it be, Jasmine? We know that this is a neuroendocrine tumor. Yes. So if it's a neuroendocrine tumor, what should we be doing, Jasmine? Along with showing that this is a neuroendocrine tumor with cytokeratin and synapto and also the pan CK, there is another thing that we need to do. Anybody?
67.
Ki-67. Excellent. Who said that, Jasmine?
Yes, ma'am.
Excellent. Yes. So this is Ki-67. Now you tell me, is the Ki-67 high or low? Ki-67 is a labeling. We count it's a labeling index for proliferation. So is it high or low, Jasmine?
It's low, ma'am.
It's low. Right. Why do you say it's low when you see so many of these brown dots? Jasmine? You can see a lot of these brown dots here. All in this. So why are you calling it low?
And the tumor cells have not taken it up much.
Exactly. Jasmine, full marks to you. The tumor cells have not taken up these brown dots, which means that the labeling, Ki-67 labeling of the tumor cells is low. So what has actually taken up the brown dots, Jasmine? Which cells have taken up the brown dots?
The internal control, the foveolar.
Yeah, what is that internal control now? Tell me. What is
Foveolar glands, ma'am.
the foveolar epithelium? Yes, but why has it taken it up? You see lots of foveolar epithelium that has taken it and lots that have not taken it. The gastric glands, the few gastric glands that are here have not taken it up. Why? And why has some of it taken it up? Come on, Jasmine, you know the answer. Just have to think. We know that Ki-67 is a labeling index, right? It's labeling those cells that are proliferating. So what does it tell you, Jasmine?
That these are proliferating, so these are stem cells.
Proliferating cells. So what do you think is proliferating in the foveolar epithelium?
Stem cells in it.
Yes. So yes, obviously they are stem cells or they're regenerating cells, no? Because this is a chronic gastritis, so it is the regenerating cells or original stem cells which are now in mitosis. Excellent, Jasmine. I think that you've done very, very well, and all of you are doing well, although you have not actually seen these slides. Okay. So we got further clinical history on this case, and this patient was diagnosed 7 years ago with ulcers in the mouth and an unsteady gait. Was found to be severely vitamin B12 deficient. So what do you think this patient has, Jasmine? Pernicious anemia, yes. And there is atrophic gastritis with pernicious anemia, and we know that this atrophic gastritis is occurring in the gastric mucosa, that is body mucosa, because we saw body mucosa over there, yes. And that body mucosa has undergone two kinds of metaplasia. One is incomplete intestinal metaplasia, and you should not have seen pyloric type glands in that body mucosa, but you're seeing it, which means that there is pyloric gland metaplasia as well, which happens in a lot of chronic gastritis. That when it involves the gastric body, you can get intestinal metaplasia as well as pyloric gland metaplasia. All right. So this patient has had ECL cell hyperplasia, etc., and the patient probably had pernicious anemia. All right. Now I'll just quickly show you two gastric biopsies, and I think maybe Pawan, are you there? Yeah. Anyway, this was not posted on Telegram. So we have two patients here: the wife of a physician and the father of a different physician, right? And this wife of a physician was investigated for low-grade fever and anemia. Hemoglobin was 10.2. The chest X-ray showed a mediastinal and hilar lymph node enlargement, which turned out to be tuberculosis because somebody biopsied it. But on endoscopy, because she had a low hemoglobin, you know that patients often have endoscopies to see if there is anything going on in the stomach, which may be leading to iron deficiency anemia. And there were multiple erythematous nodular lesions in the stomach, mainly in the body, and the largest one was 1.5 centimeters in size. Now, on the other hand, you had this elderly man, okay, who had a duodenal ulcer treated by vagotomy and gastrojejunostomy, which is not done anymore. So I'm pretty certain that none of you would have ever seen a patient who has had a vagotomy and gastrojejunostomy. And he was on regular follow-up. He was a very meticulous man, and he had recent complaints of dyspepsia. He had an endoscopy; it was normal. The dyspepsia persisted. So then an endosonography showed a focal thickening of the gastric wall. They did a biopsy, and it was referred to us with a diagnosis of a carcinoid tumor. Now, come on, Pawan, what are you seeing? See how similar these biopsies are, because that's how a punch looks like. Okay, anybody who takes a punch of the gastric mucosa, you will see this kind of it's almost like a triangular piece of tissue. So any of you see your gastric biopsies, you will notice it. And there is a kind of a cup-shaped depression in both these lesions. Okay, now come on, Pawan, what do you want to say about the high part of the wife and then the high part of the father? Quickly.
So, then you can see gastric glands. You can see the gland by columnar epithelium and the sheets of cells which are having round to ovoid with a moderate cytoplasm, but the hyperchromatic vesicular nucleus. Monomorphic cells.
Absolutely, you're absolutely right, Pawan. This is a monomorphic sheet, right? There are two kinds of nuclei, one a little more dense, a little less dense. Yeah, but did you notice anything about you said that you saw gastric glands, right? These are not gastric glands, Pawan. What are they? What is this? These are gastric glands? We just had a masterclass by Jesse, and you're telling me that these are gastric glands?
No, no, no.
Hmm.
Foveal.
What is it?
Foveal.
Yes, it is foveolar epithelium showing regenerative atypia. And what else? What else do you see? Huh? Pavan, you can't see anything else? All right, somebody has to help. Huh?
Pseudo stratification.
Stratification. That's because there is pseudo stratification of the nuclei because there is regeneration. Yeah. Come on, Jasmine, help him. What else do you see? Jasmine? Jasmine's going to decided to retire from the field. No. Sindhu,
Ma'am,
what
what
do you
did
see? Can I point it out? What are you seeing here, Pavan?
So,
What are you seeing there?
cell with the clear.
Cells with a clear cytoplasm.
Public.
Now, Pavan, I need to knock you on the head. Is Pranav there? Has he woken up? Pranav, are you there? He's disappeared. Has Pranav disappeared, Ruchi? He's disappeared. Amrita, what do you see?
Metaplasia.
What
What kind
metaplasia?
of metaplasia?
Well, you see goblet cells. Look at the goblet cells. Okay, the normal foveolar epithelium, Pavan, looks like what you are seeing here. All right, can you see this bottom thing? Okay, do you see this? This is a goblet cell.
Yes,
Right,
yes,
that's a goblet cell. This is just neutral mucin secreting epithelium that you see here. Okay, and if you noticed that when we looked at that case that Jasmine just described, look at the nuclei. They're all situated at the bottom, and that's why you saw that those nuclear dots where you saw the labeling of the Ki67 is here, no? Because it's at the base. But you are seeing goblet cells. You are seeing goblet cells here too. Can you see the goblet cells? So
Yes,
this
yes.
is foveolar epithelium that is showing regenerative atypia, which you can see on the right hand side. Yes, there is regenerative atypia, and you can see goblet cell. This is regenerative atypia. Yeah, pseudostratification, etc. Agreed? Yeah, Pranav? Very good. No, Pranav. Pavan. Now what's happening on the right hand side? What do you see? Now what's happened to you? Why can't you describe what's happening on the right hand side? Chalo, Pavan.
You can see cells.
What are these cells that you're seeing here? What are these? What structures are these at the bottom?
You can see
Foveolar. Wonderful. Absolutely right. Look, all of this is foveolar epithelium. Okay? Excellent. So there's foveolar epithelium. And then what is this? What is the other thing that you're seeing? All of this. Can you describe it, please, Pavan?
this one.
What?
Does
Does it look what
sheets
like
of
what you
cells.
see? Yes?
Sheets,
Yes,
sheets of
please.
cells.
Sheets. Yes, well, they are sheets. They are also
Between islands. Islands.
there are tuberculi, there are
The
pores.
tubercules
I don't
are
think that you see islands
small,
because when you see an
density.
island, how does an island
Density.
look? What is an island, Pavan?
Like the
What's an island?
cells grouping or group.
Yeah, it's a group of cells
Group of
surrounded
cells,
by
surrounded.
other cells which do not look the same. Otherwise, it can't be an island. No, it's like what you see in a sea. Yeah, okay. So there are no islands here. I
Yeah, no
see that
islands,
there are tuberculi. I see cords. I see tuberculi. But I see something else. Okay, I see pleomorphism, which you're not seeing on the left-hand side. Yes or no? The nuclei don't look all the same. Yeah. So now there's something funny, but okay. This may be that on the left-hand side you've got something that is, low grade, and maybe something that is high grade. So now we have to know what are we looking at. So what do you think we should do, Pavan? What do you think is on the left-hand side, and what do you think is on the right-hand side? Come on, take a guess. Neuroendocrine. Okay, on both sides.
From left side,
Right? We have to prove it. Okay. So we did promogranin A. Now tell me, Pavan, what's the diagnosis? So what's the diagnosis on the wife?
wife or
Yes.
neuroendocrine
Tumor. Yes.
tumor. Yes,
Which
father.
some people will call a carcinoid too. Yeah, that's the name. But this is a
Father
neuroendocrine
side?
tumor. On the father side, yes.
No,
It is not, no?
not it doesn't
What
look
is it
like
then? Has the stain worked on the right side?
no, made.
Has it
It hadn't
worked?
taken any stain. It hadn't taken any stain.
It hasn't taken the stain. I know that the tumor hasn't taken the stain, but has anything else taken the stain? Huh? See, it has, no? So what are these? These are neuroendocrine cells which are present in the normal gastric juice. Yes. So this stain has worked, except that the tumor has not marked with that stain. So therefore, what are we seeing, Pavan, on the wife, and what are we seeing on the father? Come on, Pavan.
Wife, we can go from neuroendocrine tumor.
Oh, very good. And the father?
Father.
Anybody? Amrita? Come on, Amrita.
It's not a malignant cell.
Yes, it is an adenocarcinoma.
Adenocarcinoma.
Yes. Okay. So this is, you see this multiple well-differentiated gastric neuroendocrine tumors, and then you have also a gastric neuroendocrine hyperplasia. Some people call it carcinoidosis, and on the other side you have a poorly differentiated adenocarcinoma. So you see, doing these stains help you to be able to tell the difference between some things that look the same. All right. Now here is another case. I'll just go through it rapidly. There's an adenocarcinoma on the right side, and this patient had a resection of the lower end of the esophagus and the proximal stomach. It is an intestinal type of adenocarcinoma of the stomach, and the margins were grossly free of tumor. Okay. Now, Sindhu, you like to tell me what this is? This is seen at the margin.
These are
Huh?
goblet cells, ma'am.
Yeah, there's a goblet cells, which is the black arrow. And what is the blue arrow? What's the blue arrow, Sindhu?
Um,
Come on, Sindhu. What is it? Anybody wants to help Sindhu? Jasmine? You see the blue arrow? You see these? Describe them, Jasmine.
These are
What is the pattern? What would you call this pattern?
papular pattern.
Sorry? What's the pattern?
Papular pattern.
What?
Mama, tubular pattern.
Tubular, right? That is, they're tubules, or they are small nests,
Also.
right? So they're all small nests of
Nests.
monomorphic cells, and you've seen so many of them so far. We saw that in the case that was given to you, and now we're seeing them. So what is it, Sindhu?
Neuroendocrine.
Endocrine cells. I'm just showing you this so that you should be able to recognize them. Look at them, the same kinds of cells. Then you see the gastritis, you see the eosinophils, you see the gastric glands over here, an occasional gastric gland, and you are seeing neuroendocrine cells, and it's marked with chromogranin A. You see that? All of these. You also see the hyperplasia in the gastric mucosa over there. So this is gastric microcarcinoidosis associated with ECL cell hyperplasia. This patient had a gastric carcinoma and also had ECL cell hyperplasia. You know that both of them can coexist, because when you have atrophic gastritis and you have ECL cell hyperplasia, the same stomach can also give rise to a gastric carcinoma. All right, very good. Now there are 3 types of gastric carcinoid tumors, and I'll just tell you that type 1 is what we have seen so far. Okay, there is parietal cell loss, and you get hypochlorhydria. You know that the first one had pernicious anemia. The other case that I showed you, the wife, she had some atrophic gastritis from probably taking proton pump inhibitors, because that also gives you ECL cell hyperplasia and an atrophic like gastritis. And this third patient had gastric atrophy and had loss of parietal cells, and the patient developed a adenocarcinoma associated with this atrophic gastritis. So type 1 is associated with parietal cell loss. Okay. Type 2 is associated with parietal cell hyperplasia. Why? Because these patients have the Zollinger-Ellison syndrome associated with a gastrin-secreting tumor. So when you have a gastrin-secreting tumor, that gastrin stimulates the ECL cells, and the ECL cells produce, get the parietal cells to produce large amounts of acid. Okay, and that's usually associated. But where is the gastrin-secreting tumor? Where do you expect that gastrin-secreting tumor to be? Pavan? Is it in the stomach or is it elsewhere? Gastrin-secreting tumor, Pavan, is not in the stomach. It will be in what is known as the gastrin triangle, right? In which it can be in the duodenum, it can be in the head of the pancreas, it can be somewhere near the gallbladder or wherever. But there is that triangle, and in that triangle, you can get a gastrin-secreting neuroendocrine tumor. You very seldom get a gastrin-secreting tumor in the stomach. Okay, and then you have this type 3, which is not associated with hypergastrinemia. Okay, now do you notice that type 1 has hypergastrinemia, type 2 has hypergastrinemia, but one has hypochlorhydria and the other is hyperchlorhydria. I think it's worth you guys understanding this. Okay, type 1 and 2 are more or less they're all tumors. They can metastasize, and they do. All neuroendocrine tumors have the ability or the proclivity to metastasize. They are potentially have the potential to metastasize, but these type 1 behave in a relatively benign fashion. Hardly anything happens to them, despite the fact that they may have metastasis. Type 2, yes, they do metastasize, but most of the deaths occur from if it's not treated well, or the tumor does not respond to treatment, then they die from Zollinger-Ellison syndrome with gastric ulcers and really very severe mucosal disease in the stomach. Type 3 is unpredictable. They often metastasize, and it depends on the grade of the tumor as to what happens to these patients. Now, just so that you understand, see, here is gastrin in the stomach, okay, which is produced by the gastrin-secreting G cells. You have gastrin stimulates the ECL cells to produce histamine. Histamine stimulates the parietal cells to produce acid. The parietal cells, when there is acid acts on or is sensed. The level of acid is sensed by the D cells in the gastric mucosa, which are the somatostatin cells. They secrete somatostatin, and then there is a negative feedback on gastrin. So this is the complete cycle. So you don't keep getting gastrin being produced, in large amounts and continuously. Then once the acid reaches a certain level, somatostatin then shuts off the production of gastrin. Now, will any one of you? There are 4 of you, and maybe those who want to answer in the chat box. Which of the 4 cells that you see over there, G cells, ECL, parietal, and D cells, which of these 4 is not a neuroendocrine cell? Come on, Sindhu. Which is not a neuroendocrine cell?
Acid parietal cells.
The parietal cell. Very good. Who is that? Pavan?
Yes, ma'am.
Yeah, Amrita?
Yes, ma'am.
Yeah,
Parietal
it's a
cell.
parietal cell. So what do you say in the chat box, Devrati? Anything in the chat box?
No, madam. No, they're saying parietal cells only.
Yeah, obviously. So it's the parietal cell. Yes? Good. Now, what happens with autoimmune gastritis or proton pump inhibitors? What do you think will happen? The parietal cells are destroyed, right? Or proton pump inhibitors actually inhibit the production of acid. You know that. That's why we give it. So if you have low acid levels, that feedback mechanism through the D cells does not exist, and therefore the D cells will not shut off the production of gastrin, and you'll see large amounts of gastrin, which will then stimulate the ECL cells, and you will get hyperplasia. Okay, so you'll get ECL cell hyperplasia, you'll get gastrin secreting neuroendocrine cell hyperplasia. On the other hand, when you get a gastrin secreting neuroendocrine tumor, which may be anywhere, it may be in the pancreas, it may be in the duodenum, it may be in the gallbladder, very seldom in the stomach. So what happens then? There is huge amounts of gastrin being secreted by the neuroendocrine tumor, and that gastrin levels are high. So because you have gastrin levels high, high levels of gastrin will cause ECL cell hyperplasia. ECL cells will cause parietal cell hyperplasia, which produces lots and lots of acid. Okay, there's nothing wrong with the parietal cells; they're not destroyed. The patient is not on proton pump inhibitors, so the parietal cells will undergo hypertrophy. But what is happening is that the somatostatin might try its level best to stop the gastrin production, but the gastrin production cannot stop. Why? Because there is an autonomous gastrin secreting neuroendocrine tumor. Have you understood this whole issue? Well, if you have, I think we'll go. So if any of you are interested, what's happening in the stomach, this is a really good article. It's in Physiological Reviews, and it tells you the physiology of gastric parietal cells. So what is happening, and it's, whatever I told you is very simplified. There is a whole lot of other stimuli that occur. There's the vagus nerve, there's acetylcholine that comes in, and there is a new hormone which many of us don't even study, or perhaps you guys do. It's called ghrelin. Okay, so there are stimulators and there are inhibitors of acid secretion. Okay, now this is just to show you what is a type 3 gastric carcinoid. And this patient had a large polypoid enhancing lesion in the superior wall of the body of the stomach. This is what the cells look like. This chromogranin. Here also there is a monomorphism. This patient had a gastric carcinoid type 3. So it's about, this is not associated with hypo or hyperchlorhydria, and definitely not associated with hypergastrinemia. Okay, good. Now we come to number 3. Who wants to take this? It's an easy case. I kept this easy case for people who hadn't done much histology. So you've done 3 months of histology, right, Pawan?
Yes,
Come on. So read the history and we'll quickly go through this.
29 years old, presented with pain in the abdomen.
Yes.
CCT shows well-defined 6 centimeters solid mass, intending into
Vaginal lymph, yes.
intra findings a knotted mass of bubble loops found in the left iliac fossa. Cross-examination, dark reddish brown mass in the mesentery.
Yeah, so you can see it. No, the forceps is showing you that mass and the cusp is that mass. Yes, okay.
Yes, no.
This is the mass. Come on. Come on, Pawan. This is a spot diagnosis, Pawan. What do you see? This is very low, Pawan. So what do you have to ask yourself, Pawan?
Is there a normal histology? Normal
tissue, yes.
Normal tissue or any abnormal tissue?
Correct. So do you think there is any normal tissue here?
I think RBC's blood clot.
Blood clot. Okay.
Yes.
All right. Anyway, let's just write this, Pawan. Come on. What do you see here?
The thrombosis.
Thrombosis. Why are you calling it thrombosis? You think this is a very large vessel which is thrombosed? Which one? This one? Or this one? Okay. And what do you think all these little spots are? Come on, Pawan. Anybody? Come on, Jasmine. What are you seeing here?
Spleninculi.
See, I told you it is a spot diagnosis, Pawan. And why did you say that these are this is a spleen or spleninculi, Jasmine?
There's a red pulp in the lymphoid areas.
There is red pulp and there is white pulp. Yes, very good. There is a thick capsule. Can you see this thick capsule? And there is red pulp and there is white pulp. Do you agree now, Pawan?
Yes, ma'am, I do.
Yes. So this is the spleen, and the question is, see this thick. You have the white pulp over there. You see an arteriole in which you get the inner lymphocytes, which look dark, and then you have an outer rim of lymphocytes. The inner rim is the T zone, and the outer rim is the B zone, and then you see these trabeculae, which have come from the capsule and are dividing up the parenchyma of the spleen. See this? Okay, very good. So this is the spleen. Now the only question we have to ask is, why is there spleen in the mesentery? So what do you think, Pawan? Why is there spleen in the mesentery? Any thoughts come to your mind? Amrita, why is there spleen in the mesentery? So the principal cell in this lesion is what, Pawan? It's the lymphocytes, right? And what are the other features we noticed? Nodules, thickly encapsulated lesion. You see the collagenous trabeculae, lymphoid nodules surrounding arterioles, and there is this ramifying network of vascular sinusoids associated with lymphoid cells. See that? Yeah, very good. Now, what is the crucial decision over here? That's why we need to find out, why do we get a spleen in the mesentery? So which is this decision-making tree? Which would you pick as the crucial decision?
I think it's pathological condition.
Physiological or pathological? Okay. Is it
Pathological.
congenital or is it acquired, right? So it's because you can get spleen in some very odd places in a congenital way or even in an acquired fashion. All right. So now this is what we saw, and this is splenic tissue in the mesentery. Excellent. And we know, look, this is just something that I did. You know that the vascular sinusoids of the spleen are very strange. Yes, they express CD34, they will express ERG, they will express CD31, but they express the T cell marker CD8. And so we know for certain that this is the spleen because there is no other vascular sinusoid that expresses CD8. Okay, so just remember that as a thing. So splenic tissue outside of the left hypochondrium. It can be an ectopic spleen, okay, which is an ectopic spleen. Yes, it can be an accessory spleen, or it can be splenosis. Okay, so what do you think it is, Pawan? Ectopic spleen?
Ectopic spleen, I think.
Or accessory spleen or splenosis. So let's ask, what is an ectopic spleen? An ectopic spleen is nothing but a spleen which has a very long vascular pedicle. So it wanders outside of the left hypochondrium. And it's there's only one spleen, but that spleen is not anchored in the left hypochondrium, so it wanders about in the abdomen. That is what is called an ectopic spleen. What are accessory spleens? That means you have a spleen in the left hypochondrium, but elsewhere you can have other spleens, and these are all the different places where you can get accessory spleens. So this. And finally, you have splenosis, and that happens when the spleen ruptures. And the spleen can rupture as after trauma, sometimes after, if it's very swollen with infection, it takes very little to make that spleen rupture. And you can have it depending on, this is a case that we saw in which there was splenic tissue in the thorax. And this was biopsy because people didn't know what it was, and it was the spleen. And this man had in the past a bullet injury in which obviously the spleen had ruptured. He had his splenectomy done, but parts of the spleen had gone into the thorax and lodged over there. Now, our particular case, this is the additional information, okay? The spleen and splenoles reported on, CECT, were in the usual anatomic site. They could see that, and there was no long vascular pedicle or whatever. So this is accessory splenic tissue in the mesentery. Very good. And now we come to the last case. Who wants to take the last case? Has everybody had a turn? Sindhu, did you have a turn?
No, ma'am.
All right. So come on, Sindhu.
32-year-old female presented with scalp swelling for 4 years, and now it has got ulcerated.
Ulcerated. And there it is. There's a very small ulceration on this thing. Come on, Sindhu. What do you see over here? Now, this is very low power, Sindhu. So you have to say what you see at low power. What are the questions you're asking yourself?
Normal tissue and abnormal tissue present or not. We can see the lining here, ma'am, and
You can see a lining. Is there any normal tissue, Sindhu? No normal tissue you're seeing?
it's present, ma'am.
It is. So what is that normal tissue? Come on, Sindhu. What are you seeing? You don't see any normal tissue, or you do?
I see, ma'am.
You're seeing it. So you want to ask for annotation and show me where you're seeing this normal tissue and what is it? You asked for annotation? No? Ah, there. All right, come on, Sindhu. I've approved it.
These areas are showing the
So
areas.
So what is this? What normal tissue is this? Very good, Sindhu. You marked it. So which normal tissue is this?
Normal scalp.
It is normal scalp skin. And we know that it is normal scalp skin because what does normal scalp skin, what should it show, Sindhu? How do you know that this is scalp? This is skin, without a doubt. Is it the palm and sole, Sindhu?
No, ma'am.
Why? Why?
Hair follicles are seen along
Oh,
with
it will not. The palms and the soles will not show hair follicles. Excellent. Right. So you have hair follicles. So why is it the scalp? Sindhu, look at the number of hair follicles. Sindhu. Huge numbers of hair follicles. So it's either the scalp, or if it is a male, then it could be the beard. No, it could be the area of the beard. Unlikely to be a female face, but it could be a male face. Yes, it's possible. But so this is very hairy skin. That much we know. And we have been told that it is a scalp. I showed you the picture. So this is, yes, we can believe, Sindhu, that this is the scalp. No, it's not come from some skin from the palm or sole or from, a female. And this lady is a female. So it's not a face. Okay. So very good, Sindhu. So there is normal scalp skin. Now tell me, what else do you see? Is there any abnormal tissue, Sindhu?
Yes, ma'am. The abnormal
Yes.
tissue is present and it is seen infiltrating the.
Now, what is the relationship of this abnormal to the normal, Sindhu?
Ma'am, the subepithelium is infiltrated with the
Yes. So you are right, Sindhu. Absolutely right. You noticed that this. Oh, come on. Oh, my thing is not. It's gone to sleep. Oh, gone. All right. You noticed something very interesting, no, Sindhu? That here is the scalp skin, and you see the epidermis, and I'm pointing it out with my cursor. And you see that epidermis continues absolutely intact, except for a small area here where it is ulcerated, and it is completely intact. So that's what you noticed, Sindhu, and full marks to you for noticing that. Okay. So whatever this abnormality is, it is not arising from the epidermis. Do you agree, Sindhu?
Yes, ma'am.
Yes. So whatever this is, and even from here you can make out that this is an epithelial lesion, no? It is an epithelial lesion. It is occupying the papillary dermis. Well, actually, the scalp doesn't have a good papillary dermis, but it is occupying the upper dermis. It is gone through the upper dermis, and it is there now in the lower dermis as well. Yeah, you can see that, right, Sindhu?
Yes, ma'am.
So this is the importance of trying to know or trying to ask yourself the question, what is the relationship of the normal or the abnormal to the normal? So we know that this is not an epidermal lesion. It is a tumor. I can see that. Okay. Now, what is the pattern, Sindhu? So this is a dermal lesion.
The pattern is
Pattern, yes.
islands of cells
Very good. Yes.
and some trabeculae pattern is also observed.
It's interconnecting. There's little cystic spaces, right? So there's it's solid and cystic spaces, and they are interconnecting with each other. Yes. But there is something else you notice. Have you noticed, Sindhu? What else have you noticed? Okay, that's all that you're seeing here. Anything else? What do you think this is at the bottom? What is that? Does it look like what you're seeing on top?
Yes, ma'am. Epithelium.
So there is a lining, no? There is a big cyst. Can you see? There's a cystic space because there's nothing filling the cystic space, right?
Yes, ma'am.
It has got a lining. So there is a large cyst in the deep dermis, which is connected to whatever is happening in the upper dermis and the mid dermis. Do you agree, Sindhu?
Yes, ma'am.
Yes. So now we have to decide on our fifth question. What do you want to see on high power? Come on, Sindhu.
The
Where do you
abnormal,
like to go? Where do you want to see?
and the abnormal area,
Oh yeah, there's lots of abnormal areas, Sindhu. So which part of the abnormal area?
ma'am, near the cystic region.
Near the cystic region. All right, let me see if I've gone there first. No, I went on top. Okay, so come on. I'll show you the cystic region a little later. But come on. So what do you see here? Can you at least tell what cell type it is? And it is definitely in the dermis. Look, the epidermis is completely intact except for this area where it is ulcerated. So this is a dermal lesion, which is now growing to impinge upon the epidermis. But it's been growing for 4 years. So come on, what do you think the cell is that you're seeing over here, Sindhu? I'm just showing you one edge of this lesion where the ulceration is. This is the mid portion of this lesion. Can you see what the cell is? What do you think the cell is? This is the other part.
All the cells are looking pigmented, ma'am. And
It's looking pigmented. No, I don't think it's looking pigmented. Here you wanted to see your cyst, no, Sindhu? Here's the cyst.
Okay.
All right, here's the cyst. You can see the cyst. Then you see all these spaces. It looks like there is cheminonecrosis, right, Sindhu? Yes or no? You know, you've heard about cheminonecrosis. You've done only, how long have you done? 3 years. 3 months. Have you heard about cheminonecrosis, Sindhu?
No, ma'am.
No, you haven't. So I don't blame you for not being able to say that. Now, where is Jasmine? Jasmine, you know what is comedo-necrosis? Jasmine?
Yes, ma'am. The central necrosis seen.
Central necrosis, that means you have an epithelial island or group of cells, and the central part of it is necrotic.
Necrotic.
And this usually happens in breast cancer or some other kinds of cancer where you have islands of cells, and here you have islands, and in the center of these islands you see this necrotic tissue. Right? Good. Now you see that, and this is what is called comedo-necrosis. Does everybody agree? Pawan, you agree that this is comedo-necrosis? Yeah, Pawan? Yeah, okay. Now I'll show you the edges of this. Now can you identify something over here, Sindhu?
Yes, ma'am.
What do you see? There is necrosis, that is to the top here, but what are these? These you will have seen. Yeah, what is it? This is keratin. Have you seen keratin before, Sindhu? You saw pearls? Yeah, so these are pearls, okay? These are keratin pearls. And these keratin pearls you see over here, and this part has got, I'm not sure whether this is necrosis or this is just the keratin is losing its cellular character and it's just got nuclei that are left in the keratin. But this is something odd. Yeah, now here also you see keratin. Amrita,
Yes, ma'am.
are you there?
Yes, ma'am.
What is odd about this? You've got keratin, so there must be squamous differentiation.
Yes, ma'am.
Yes? So what do you notice about this part of this? Yeah, what is it that you notice that is odd? If this is squamous epithelium, what is odd about it? Anything that strikes you as odd, Amrita?
Um,
Do you expect to see clearing?
No,
in
ma'am.
this
Woman, these
cytoplasm?
cells here.
The cells are
Clear.
clear. Now, Amrita, these are definitely clear cells.
Yes.
Yes?
Yes, ma'am.
Can you see them?
Yes, ma'am, these-
As opposed to what you saw as vacuolated cells in the first case that you said, this
ma'am.
is clear. There's no two ways about that. And it has a box-like cytoplasmic borders. Can you see them? They're extremely well. Now, that is very odd for squamous pearls to occur in this kind of epithelium. Yeah, there is also a lot of basiloid change. Can you see over here where you see less cytoplasm and a lot more nuclei? That means the nuclear cytoplasmic ratio is increased. And when you see that, that's what you see in basal cells, right? So there is a basiloid component to this. There is a clear cell component, and there is, of course, keratinization. And you see here, this keratinization looks as if it is infiltrative. Oh, come on. Sometimes this thing just doesn't. Sorry, but I'll have to do this until my mouse is not behaving itself.
What happened?
My mouse is not. Wait a second. I need to just get rid of this. It'll happen, but
Yeah, I can see the mouse.
now it's gone. so because I want to move to the next slide, no? Now you see this? Again, you have got that same kind of clear cytoplasm. And here you're seeing necrosis. There's no two ways about that. Yeah. And here you see a very frank infiltrating squamous carcinoma. Do you agree, Amrita?
Yes, ma'am.
Yeah. I think even Pawan, who's done 3 months, and Sindhu, who has done 3 months, can tell that. Jasmine has done 5 months. So this is no doubt about it that there is an invasive carcinoma which is showing you squamous differentiation. So we are seeing squamous differentiation in this tumor. Now see, it's even more invasive as you see here. But when you come to another part of this tumor, that invasion is no longer squamous. There is squamous invasion that you see here at the top of this slide, and then you see cords of cells. This is what we call a cord. This pattern is a beautiful pattern for a cord. You see the long, thin cords like you see in one of the better examples is that of a lobular carcinoma of the breast. And we talk about something growing in Indian file. That means one cell or behind the other, and it's called Indian file, not because of us Indians, but because of the Red Indians who used from the native Indians of the United States of America, the American Indians that used to go hunting in a single file. So that's why it's known as Indian file. See this? One behind the other, behind the other. Now that is quite different from what you're seeing here. So you've got 2 different patterns of the infiltrating tumor over here. You also have some very strange looking areas in this tumor where you have keratinization, and yet you have some very clear looking cells. You see all this now? I've depicted everything, including this cystic lining, which also has those clear cells. So what is the principal cell in this lesion? I don't expect you to answer that because all of you have not seen these slides, but if anybody wants to attempt it, I think Jasmine is, or Amrita, what is the principal cell in the lesion? Squamous cell?
Clear cells.
Yeah, so what are those clear cells? And it's an epithelium. It's an epithelium which is showing you squamous differentiation, it's showing you basiloid differentiation, and it has got these things that almost look like they are, like I told you, like something like a breast tumor. So it's got very mixed characters, okay? When you see these mixed characters, then you should think of something, and there is a cyst as well. And that is the trichilemmal epithelial cell. Now, what is trichilemmal? It means trich is what? Hair, right? And lemma is what? Is sheath. Okay, so this is the hair sheath. And you have a hair, and it has an outer sheath, and it has an inner sheath. Okay, and this kind of differentiation is characteristic of the outer root sheath. Okay, so clear cells, differentiation towards squamous epithelium, basiloid cells, and if it turns malignant, then you get this kind of infiltration in the form of cords. So what are the other features? We've described all of them. There's a cyst lined by trichilemmal epithelial cells. There's a proliferating trichilemmal epithelial clusters, and there's central necrosis and abrupt keratinization. That's because keratinization, which goes towards the epidermal type of keratinization, shows keratohyalin granules, which are not seen over here. And so this is a trichilemmal carcinoma arising in a proliferating trichilemmal cyst. Okay? And I'm just showing you the outer root sheath. So all of you, when you go and look at just normal epidermis and you see hair there, and if you ever get a chance to look at normal scalp skin, where you see really very good examples, or the skin of the of the cheek in a male, which is very hairy, you'll see this hair in the middle, and you have the inner root sheath over here, okay, which has got these very eosinophilic cells, and then you have the outer root sheath. And this outer root sheath shows you exactly the kind of clear cells that you saw in this particular example. It's a really wonderful example of tricholemmal cyst, which was proliferating, and you see lots of examples on the scalp of proliferating tricholemmal cysts, and this one has over the years now turned malignant. So I think we have finished. I really want to congratulate all of you. I think this is my last slide. I will stop sharing my my slide. And yes,
Ma'am, there are two questions.
very good. Of course, I will take the question. Let me stop sharing this slide. Yeah. But before I take the questions, I really want to congratulate every one of these students. They were interactive. Many of them had done less than 3 months in histopathology, but they answered the questions and they were excellent because they had not seen the slides and had not discussed it with their, their departments and their seniors. So all of you, I want to clap and say that you did a very, very good job, all of you. All right. So now tell me the questions.
First one is, what is the difference between keratin pearl and keratin cyst?
Keratin pearl and keratin cyst. A keratin pearl is a structure which has got keratinized cells in the center. Okay, and the non-keratinized cells at the periphery. It's the same thing as what was the question?
Difference between keratin.
Keratin cyst has to be cystic. No, a keratin pearl is not cystic. So it has got a solid, keratinized squamous cells right in the center, and you have non-keratinized cells around. It's usually a small structure, exactly like how I showed you. But what was the other thing? Keratin pearl versus what?
Keratin cyst.
No. There was another term that was also used.
Keratin pearl or squamous pearl and keratin cyst.
Yes, keratin pearl, squamous pearl is the same thing. So you can say a keratin pearl, you can say a squamous pearl. It means the same thing, that it is keratinized. There is another name another term that we use, and that is squamous morule. All right, and you will come across it. Now, a squamous morule has the same structure. It's got a little whorl of squamous cells, but it is not keratinized. Okay, so when you have a non-keratinized little whorl of squamous cells, then you call it a squamous morule. If it is keratinized, you call it a pearl. And why do we call it a pearl? Whether you call it a squamous pearl or you have a keratin pearl. Can somebody tell me why you call it a pearl? Has anybody ever seen keratin? Which, yes, you see your keratin. You have nails which are keratin. You have a lot of skin squames that are keratin. But when you see keratin, it is white. It's densely white and it has a sheen to it. So if you come across one of these things, when you cut it, you will see it sitting like a little pearl. And that's why it is called a keratin pearl or a squamous pearl. Okay, because it is densely white and it has a sheen to it. Okay, good. So what are the other questions?
Ma'am, will it make a difference if this was called a high-grade carcinoma with keratinization instead of tricholemmal carcinoma?
No, it doesn't make any difference at all, except that tricholemmal carcinoma is not just an entity. It is, you saw it here. You saw the tricholemmal cyst. So this lady, first and foremost, had a hair follicle cyst. Okay, with the cyst was composed of cells that formed the outer root sheath. Okay, and that lay there for a time. Then it started to proliferate, and it became a proliferating pilar or tricholemmal cyst. Okay, it's more or less the same entity because it comes from the root sheath. Pilar meaning hair. So you get a proliferating tricholemmal cyst, and now it has become a carcinoma. And it is a carcinoma that is showing you two different lines of differentiation. So it's not a typical squamous carcinoma. When you ask me, will it make a difference? Will it make a difference to the patient, to the patient's treatment? No. Once it's a carcinoma and it's infiltrative, and this patient will probably require adjuvant radiation therapy or something to that particular part. But to mistake a proliferating tricholemmal cyst for a squamous carcinoma is, yes, that would be a serious mistake. Okay, so you have to be able to identify this tricholemmal differentiation. And when you see tricholemmal differentiation and you start to see keratinization in tricholemmal differentiation and a very abnormal proliferation, please stop and think. I'm seeing these very peculiar clear cells. I should not see that in a normal squamous carcinoma, and yet I'm seeing keratin pearls. Let me stop. This is not a squamous carcinoma. This is a proliferating tricholemmal cyst. Okay, our case went even further than a proliferating tricholemmal cyst. It became a squamous or a tricholemmal carcinoma arising in a proliferating tricholemmal cyst. So it would be wrong to call a proliferating tricholemmal cyst, which is benign, is squamous carcinoma, and it looks a lot like squamous carcinoma because you saw the pearls and other things that arise in that. So that makes a difference. But if you've got a carcinoma, no, it doesn't make a difference. Are there any more questions?
I had it down.
Oh, very good. Who's this now?
Ankita.
Chakravarti?
Ma'am,
Yes.
Ankita, our moderator.
Oh, Ankita. Sorry, yes, Ankita.
And squamous eddies are the same as squamous modules, is it?
Yes, they are. Yeah, eddy, and eddy is a word.
Yes.
Okay? It comes from the same word. You know, when you have say in a basin, you have put a plug into the outlet, and you fill the water, and then you suddenly pull that plug. You see the water forming a whirl
Eddy
as
currents,
it goes
yeah.
down into that is an eddy.
Yeah.
Okay.
Yeah.
So anything that has this kind of whirl like thing, you get the picture. Is an eddy.
Eddy,
Yes. A module, an eddy is more or less the same thing. But when it keratinizes, then we should
The
use
pearl.
a pearl. Okay. It's just the usage of these. You know, we have to learn and understand the language that pathologists speak because we are pathologists and we have to learn it so that other people understand what you say and you understand what the textbooks say and other people say. Yeah.
Yes. Thank you, ma'am.
Anybody else? No? Okay. I think now we've had a very long session. Once again, all of you, Sindhu, Jasmine, Amrita, Pranav, I don't know, you disappeared somewhere in between. Pawan, thank you very much. I congratulate you because you had no help at all and you did such a wonderful, wonderful job. So thank you. I wish, more students would, sort of be like you and talk, because when you talk, you are representing all of the other students who are chatting in the chat box, and I see many people were answering too many hair follicles in the scalp and an excellent one. So congratulations to all.